Hello, I'm Dr. Swapna Nair, and today I'm going to take you through a presentation on basics of COPD. Is COPD or chronic obstructive pulmonary disease an important disease? Do you know the burden of the disease in India? In the year 2019, COPD was the second leading cause of total number of deaths in India and the third leading cause of deaths and disabilities combined. There were around 55.3 million cases of COPD in India in the year 2016, and these numbers are ridiculously underestimated as a lot of cases of COPD go undiagnosed every year. Smoking and exposure to biomass or chula smoke are the major risk factors of COPD, and the disease generally occurs in people above the age of 40 years. Apart from these, ambient air pollution, occupational exposure to smoke, recurrent lung infections, and long-standing asthma are also risk factors for COPD. Dyspnea or shortness of breath, chronic cough, and sputum production are the symptoms of the disease. These symptoms are progressive in nature, that is, they worsen with time. So, what is COPD? Let's break up the definition given on this slide, which is taken from the GOLD guideline or the Guideline on Chronic Obstructive Pulmonary Disease. COPD is a preventable and treatable disease. This means that COPD can be prevented if exposure to risk factors such as cigarette smoke or chula smoke are avoided. And if a person gets COPD, it can be treated or managed but not cured. As the name suggests, this disease is chronic in nature, that is, it is long term and the decline in lung function increases with time. Moving on to the next part of the definition, this disease is characterized by persistent respiratory symptoms and airflow limitation. So, dyspnea or breathlessness is a hallmark symptom of COPD. Other respiratory symptoms, as we already discussed, include chronic cough and sputum production. These symptoms worsen with time, and the airflow limitation also increases with time. All of these symptoms in COPD are majorly caused due to abnormalities in the airways, that is the bronchus, or alveoli, that is the air sacs, due to exposure to smoke or noxious particles over a period of time. To sum this up, COPD is a preventable and treatable disease that is characterized by persistent respiratory symptoms and airflow limitation, that is due to airway and or alveolar abnormalities, usually caused by significant exposure to noxious particles or gases. Now there are two components involved in the pathophysiology of COPD. These are chronic bronchitis and emphysema. So a patient with COPD may suffer from either chronic bronchitis or emphysema or a combination of both. Now let's understand what is emphysema and chronic bronchitis. So whenever we talk about emphysema, I want you all to understand that it is essentially an abnormality of the alveoli or the air sacs. Now alveoli, as you can see in the image here, are grape-like structures where exchange of gases take place. These alveoli are elastic in nature, that is, they inflate when you breathe in to incorporate all the air you breathe in, and they deflate when you exhale to help in getting all the air out of the lungs. Emphysema is a condition in which there is loss of elasticity of the alveolar walls and destruction of the alveolar walls. This leads to incomplete emptying of the lungs and air trapping. Let's look at it this way. Whenever you blow air into a balloon, it inflates, and when you open the mouth of the balloon, all the air goes out, it deflates, and comes back to its original shape. This happens because the balloon is elastic in nature. Now, if this balloon loses its elasticity, it will definitely inflate when you blow air in, but when you open the mouth of the balloon, some amount of air would remain inside it, and it will never come back to its original shape. This is exactly what happens in emphysema. Now, moving on to chronic bronchitis. Chronic bronchitis is an abnormality of the bronchus or the airways. This condition is characterized by the presence of cough and sputum production for most of the days over 3 months for 2 consecutive years. Chronic bronchitis is caused due to irritation in the airways due to constant exposure to noxious particles or gases. This irritation leads to inflammation and increase in mucus production. This in turn leads to mucus plugging, and the airways that were initially open now have less space for air to move in and move out. Mucus plugging also increases the risk of bacterial and viral infections, and these infections worsen the disease outcomes in COPD patients. Chronic bronchitis and emphysema lead to expiratory airflow limitation and air trapping in COPD patients. We will learn more about these two conditions in the future training sessions. Let's look at the signs of COPD. So, symptoms are what the patient experiences, and signs are what the doctors look for in a patient if they suspect he has COPD. Barrel-shaped chest is an important sign in COPD patients. Due to the air trapping caused due to chronic bronchitis and emphysema, there is an increase in the size of the lungs, and the chest of the COPD patients protrude out to give a barrel-shaped appearance. These patients also show pursed lip breathing pattern. On checking with a stethoscope, the doctor hears different sounds called as rhonchi and wheezing. COPD patients are generally very thin and have low body mass index. These patients have a low body mass index because they have a lot of muscle wastage and they require a lot of energy to even breathe. These patients also use their accessory muscles while breathing, so the doctor sees if their neck muscles move while they breathe. Lastly, COPD patients breathe very fast, also called as tachypnea, in an attempt to make up for the reduced amount of oxygen in their body. To diagnose COPD in a patient, the doctor first conducts an elaborate history-taking session where the patient is asked about his age, because COPD generally occurs in patients who are about 35 or 40 years of age. Then the doctor asks about his occupation, symptoms, duration of symptoms, exposure to risk factors, smoking status, and history of asthma or infections. If the doctor then suspects that this patient has an obstructive lung disease, he asks the patient to get a spirometry test done. Spirometry is the gold standard test for diagnosing obstructive lung diseases. X-ray or scans are recommended only if the doctor feels the need for carrying out further investigations. Once COPD is diagnosed, the doctor follows certain algorithms for management of these COPD patients. There are different types of drugs that are available for management of COPD patients, and as per the GOLD guidelines, the objective of COPD therapy are: A. Reduction of symptoms that include relieving symptoms of COPD, improving the exercise tolerance, and improving the overall health status. The second goal is to reduce the risk, mainly to reduce the risk of exacerbations. Exacerbations or worsening of symptoms is a very critical event in the life of a COPD patient, and it worsens the overall disease progression of the patient. This goal, that is the goal of reducing the risk, can be achieved by preventing disease progression, preventing and treating exacerbations, and reducing mortality. The mainline therapy for managing COPD patients are inhaled bronchodilators. These medicines help in keeping the airways open and make it easier for the patients to breathe. There are two types of inhaled bronchodilators: beta-2 agonists and anticholinergics. Beta-2 agonists act on the beta-2 receptors present on the airways and keep the airway open. These may be short-acting bronchodilators like salbutamol or levosalbutamol that act for 4 to 6 hours, or long-acting beta-2 agonists like salmeterol, formoterol, or indaterol that act for 12 to 20. Anticholine on M3 receptors. When acetylcholine binds to M3 receptors, it causes contraction of the smooth muscles or the airways. Anticholinergics prevent this binding of acetylcholine and help keep the airway open. Again, anticholinergics may be short-acting like ipratropium or long-acting like tiotropium or glycopyrronium. So that's all for now. We will learn in depth about COPD, its diagnosis and management in the future training sessions. Thank you.